I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Got it. Hello, my loves, and welcome back to the Love and Science podcast. I have an amazing guest today. She is a friend, she is a colleague, she is an expert in midlife women's health. Her name is Dr. Tina Segocio, and she believes that menopause is not an ending, it is an awakening. And we're going to extend that to perimenopause because so many people who are my patients and my clients, myself included, are dealing with this interesting window of time called the menopausal transition, right? She is a respected OBGYN and menopause specialist with more than 20 years of experience. She has guided thousands of women through every stage of hormonal and life transition. She's known for her compassionate approach and depth of expertise. She blends science, empathy, and real-life understanding to help women rediscover balance, vitality, and self-trust in midlife and beyond. Welcome, Dr. Tina. It is so wonderful to have you today.
Hi, Erica. Thank you so much for having me. I'm excited for this conversation today.
I know we've been thinking about doing this for a long
Yes,
time. It's like the day
yes,
is here. The day is
yes,
here.
yes. It's always very fulfilling to speak with another OBGYN, or at least,
Yeah.
originally trained, even though as you as an REI, specialist. So
Yeah, absolutely. No, I totally agree. I was so moved when I heard you speak about your own experience of going through this transition as sort of the catalyst for the work that you do now. Would you be willing to share for our listeners a little bit about what that was like for you and what motivates you to do what you do in the world?
sure. I am very open about my own experience. I always like to start off with my age because I'm certainly not embarrassed about my age, but I do think it gives a little bit of timeliness to my own story. I'm 55 years old. I have been in solo private practice since 2007 as a general OBGYN. And I opened up a solo private practice in Merced, California in 2009. And, for those of us in the training of obstetrics and gynecology, we have a special role, right? Women's health, 99.9% of the time. One of the things I really loved about being a general OBGYN for so many years was having the privilege to take women through so many different milestones,
Mm-hmm.
uh, to be a trusted provider in some of the more difficult moments of being, a female. And also, what has been very particular for me in the last maybe 5, 7 years is also the transition, the hormonal transition of perimenopause, menopause, and then following those women in the years thereafter. And I think what's
Mm-hmm.
really important to remember is that, we also were trained in the last 20 some years with a mindset that was very impacted by, the guidelines that changed, especially for women's health, midlife women's health care, as far back as 2002. And so when I
Mm-hmm.
think about my own career and how it has evolved, and how I've cared for women, that came to really impact what I was doing for my own set of patients over the last several years. And so one of the benefits of my practice is being with the same patients for, 16, 15, 16 years
Mm-hmm.
and getting older with them. And one of the things that really struck me was the conversations I was having with them were changing about our bodies and about our mental health and what's happening with my periods and then at the same time, I was realizing I was also going through it. You
Mm-hmm.
know, but as a physician, when you're very focused on what you do and you love what you do, sometimes you also put yourself in the back seat of taking care of yourself. And so
Of course.
very honestly, while I was going through my perimenopausal transition in my late 40s, uh, I was not taking good care of myself because my patients were first. My patients were first. And of course, having a family. But it really was just about not realizing that I wasn't taking good care of myself. in our profession, we're trained as surgeons. We do really intricate work in the operating room. We are, just focused on delivering babies, at that moment. And so we're required to just, be on the mark at all times.
Mm-hmm.
And as I started to go through my own experience, I realized that my memory was starting to get affected. My brain fog was really very severe for me in terms of just not having the clarity of thinking when I was in the office and talking to patients. I mean, there were times I would pause in the middle of a conversation and be, what was it that I just said to you? Or
Wow.
be in the operating room and not remembering what the name of an instrument was. And then even my own joint pain and arthritis affecting my ability to hold instruments. And so there were a lot of things that were happening for myself that I just was a little bit in denial. And
Yep.
there was a part of me that was just focused. It was very easy to just focus on my patients. But as I was aging with these patients over the years, they were asking me the same questions about what was happening in their bodies. And there came a point where it was like, oh, I am part of this group. I am part of
Mm.
this, this conversation. And I realized that as I was having difficulties maintaining my skill set in the operating room, in the delivery room, um, I really needed to think hard about what I wanted to do. And there was a point where I wanted to be done. Like I told my
Mm-hmm.
husband at the time, I want to retire. I don't want to do this anymore because I was scared.
Mm-hmm.
I was scared of hurting someone or one of my patients.
Yeah,
And that's the worst feeling, right?
it is.
And that fear really kind of held me back for a while. But I learned to really pivot and use my own experience to really start having deeper, honest conversations with my patients who are starting to go through perimenopause as well. And so
Mm-hmm.
the it just made it easier to really pivot because I was aging with these patients and the experiences we were all going through were very similar. And then it just, really gave me more purpose to really get back to the books, start listening, start paying attention, go to conferences, get
Yeah.
myself re-educated because we were not
Right.
well educated in
No.
training on midlife women's health in the years, following menopause. So it required us, or those like myself, to get back and re-educate. But I also think coming with part of that responsibility was also wanting to.
Yeah,
Because I think you and I both know the majority of the established medical field is still entrenched in the old paradigm and the old
oh
thinking.
my goodness. Oh my gosh, Dr. Tina, so part of my job right now is we staff these e-consults, which is, I mean, I wish I
Yeah,
didn't have to do this, but we do. And that means that anything that is a general GYN question from
yeah,
the entire academic universe, NP, PA, PCP, you would not believe the questions I get on a day-to-day basis. And
yeah,
like all I have to say is you're providing value to these people. They truly don't know the answers to these questions.
yeah,
Like but it's there's just such a lack of knowledge, and like
yeah,
kudos to you for being like, okay, what were the gaps in my
yeah,
education? What do
yes,
I need to do both to like help my patients and also myself at this point? Because and
absolutely.
I've experienced this in my own perimenopause journey. Sometimes there's not exactly a roadmap for what you should do, and like sometimes you think, oh, I should be able to handle this because I'm an OBGYN. But like if there
Oh,
were massive chunks empty of this
yes,
training,
yes,
there's been new insights since, right? That maybe, we haven't necessarily had a reason to keep up with. Like it's
right.
really powerful to get those skills, get that knowledge, and then to be able to help both other people and yourself.
Correct. Absolutely.
Yeah,
I mean, honestly, I could not be an impactful provider for my patients moving forward if I wasn't going to get back to basics and understand what was happening to our own bodies at this time of life into
right.
this new season. And then realizing like we are we need to reframe our conversations about how we age as women and
Totally.
really looking to the future of this 30, 40-year window in an ovarian hormone deficiency state, post menopause, of how do we take care of ourselves. And I think
Totally.
the medical establishment is guilty of this as well, of not caring after a certain age, right? Or
Oh,
after a certain
absolutely. Or
point. Right,
normalizing, oh, this is just how it is in your 40s or
right,
30s if you have
correct,
diminished ovarian reserve. Oh, this is just normal. But then,
right,
like, our life expectancy keeps getting better. And,
right.
like you said before we hopped on, you're like, I have more to give, I have more to contribute.
Yeah,
And
yeah,
so, how can we help brilliant, strong, powerful women to keep contributing, to keep being
absolutely.
sane in their own bodies? Yeah.
And I think we also have this unfortunate approach that we can be, that we're ageist at a certain point too. And I think that
Correct.
that was part of my training, that, oh, well, if she's 50, if she's 60, if she's 70, but
Yeah.
I'm meeting so many women over the age of 60 who are coming back into the offices and saying, Dr. Segocio, we've been robbed. And I go, yeah. Yeah.
Wow. Wow.
And I can't help feel a little guilty of being in my early years of practice,
I know.
of doing some of the things that I would never want to see myself do anymore or be part of. And
I
so
know.
I'm thankful to be a physician that has made the change and has been willing to re-educate herself, because my patients are looking for better care and they deserve it. And
Yeah.
I've earned their trust after 15, 16 years. And
Right.
so I want
Yeah.
to give them the best care, but you're absolutely correct. If I was going to save them, I needed to save myself first.
Right.
And, in the last, specifically in the last 3 to 4 years, I've, dialed in on what I needed to do for myself. And it's really impacted the way I show up for my patients. And so while the loss of no longer practicing as a general OBGYN, some of the best years of my career have been just in the delivery room, in the
Mhm.
operating room. Yeah, I am not unhappy with the pivot I've had to make, but I've also wanted to make in ensuring that we keep women healthy, for the next 30, 40 years, after the menopausal transition. So,
Yeah.
that has become very important to me, also as I'm aging. So that has been my own personal journey, and I'm happy to still keep at it, because it's exciting to be in this field where it's changing very rapidly.
Yeah. It's like a cultural evolution
Yeah,
and a personal evolution
absolutely.
within that. And then all your patients get to benefit.
Yeah.
Yeah.
So, which I hope so. Yeah.
Yeah. Well, I wanted to ask, so I would imagine that a number of the people you were seeing during those years and still see
Yeah.
are people in their 30s and 40s who
Yes.
are dealing with diminished ovarian reserve, infertility, perimenopause. I mean, I think the intent of this conversation really is to unpack what is it to be in that perimenopausal
Sure.
transition. I mean, we know that the changes before menopause, which is the final menstrual period, and in air quotes, right? Like that those happen 10 to 15 years before that. And so if the average age of menopause in the US is 50, 51, like we need to rewind like 10 to
Yeah,
15 years and be like, oh, I
absolutely.
know you're 36 and I
Yeah.
believe you that you have
Yeah.
brain fog. Oh, when you're trying to
Yeah.
build your family right now, like what, so let's talk about that a little bit. How do you
Yeah.
think about addressing infertility in women who are struggling with perimenopause? If you're listening right now and finding yourself nodding along, this is usually the moment people realize that they want support that's specific to them. In addition to this podcast, I offer one on one fertility consults where we look at your full picture with both strategy and compassion. You can learn more in the show notes. Now, let's get back to the conversation.
Yes, and I think again, it's going back to a point that I made about being ageist too, right?
Yeah.
Like I think it's the reverse too, like in the sense
Yeah.
that we kind of assume, oh, you're mid 30s, you're early 40s, you can't be going through all of that just yet, right?
Yeah.
And so the struggle is even more challenging for patients who are struggling with infertility, because there's this idea that there shouldn't be anything wrong with you. You're only this age, right? And
Yeah.
so you see our fellow colleagues in the field that give the kind of the BS back to the patient, saying, "Oh, just do this, just eat better, just lose weight, just do more of this, and then so we kind of have this reverse bias, for women
Hmm.
in their mid 30s to mid 40s. Um, you know, the I have one patient that just comes to mind so clearly, I had been taking care of her for several years. I actually had done a surgery on her that removed a cyst way many years back, and she eventually got pregnant spontaneously in her late 30s. She was trying to get pregnant soon after, and she was obviously bridged into her early 40s, and she was struggling. And and there was a bias at the time for me thinking, well, you got pregnant just a few years ago. Why is this, a problem for you? And we were testing and we were testing. I was not listening to the symptoms at the time as well as I should have. But we finally did some blood work and I was shocked. She was 40, 41, and her FSH was already 60.
Whoa.
And I sat there thinking, oh my gosh. And I felt so badly for her, but I
Yeah.
felt badly because I wasn't doing right by her in the beginning during her struggle.
Yeah.
So, I've had a mix of experiences in my own practice with, things that are similar. So to tell someone like that at 41, even after she had had just a wonderful spontaneous pregnancy, prior to that, that the likelihood of her not getting pregnant,
Mhm.
was high. It's heartbreaking, you
Well,
know.
yeah, it's how you were trained,
Yeah,
but it's not the truth,
yeah,
right? And so,
yeah.
kudos for recognizing that. So then what happened after that, after
So,
you discovered that?
we talked about it and I said, listen, the periods haven't stopped,
Yep.
but there's always a possibility. You never know. There's always a lot of unpredictability.
Yep.
But she, kept trying, but then stopped formally
Yep.
a few years after because it was very obvious
Mm.
that the pregnancy was not going to happen unless there were other means. So, but she accepted it, and she became much more symptomatic through the years that followed, and we started hormone therapy probably by 45.
Wow. Well,
Hormone
that makes
replacement
total
therapy by that.
sense.
Yeah.
Yeah, I
So,
mean, if you think about it, like, I was taught that, oh, it's 1% of women who have primary ovarian insufficiency. And we're talking about the tail end of the bell-shaped curve where,
right.
it used to be like two values and FSH is super high and like all those things, like 1% of the population meets these criteria. I was at the ASRM conference in October and it was like, oh, this is actually probably closer to 5 to 10%. And here's the new algorithm and all those things. And I know somebody in my practice who was an author of the guidelines. I mean, it's like
Yeah.
we're evolving. And so it makes total sense why that wasn't obvious at first. But then
Yeah.
the truth is that was probably going on for a very long time before those labs were checked. And she's really lucky that she had that little one because her
Yes.
FSH was
Right.
probably elevated then too, so we
Right.
understand. And I think that's also coupled with the fact that we know this as physicians, most of my listeners are female physicians, like, the FSH is pulsatile and like your FSH in one cycle can be very different than your FSH in another
Yes.
cycle. So we can, not that we should check it every single month, but we can be falsely reassured by, a
Correct.
normal FSH estradiol. They always have to be checked together. And then maybe the next month it's super high. I
Right.
have a patient who we checked it and it was like her FSH was like 28 after having a normal FSH in the past,
Yeah.
like recently.
Yeah.
And so I think we have to think about physiology. We have to think about like
Always.
symptoms.
Yeah.
It's not just the like hot flashes and vaginal dryness. Okay, you're fine.
Yeah.
Like you said, it's a lot of times it's the brain fog, the irritability, the poor sleep.
Yeah.
All those more vague symptoms. We really need to listen to our patients.
Right. And she was just she was only 2 years of being a mother into
Yeah.
motherhood. So, you kind of say, oh, you've got a toddler, you've got a 2-year-old, you're tired, and so even providers, we get caught in that
Yeah.
net of biases of certain things.
Yeah.
And so, yes, stories like that remind me,
Mm-hmm.
to always listen, to always
Yeah. And I
listen.
think frequent monitoring, like as I was thinking
Yeah.
about, what would be most valuable for listeners, like there's no harm in getting labs on the sooner side. The anti-Mullerian hormone, thankfully, is not as volatile, let's say,
Yeah.
as the FSH. And so, I think it's always reasonable to check an anti-Mullerian hormone in somebody who's trying to get pregnant. If they're not trying to
Right.
get pregnant, that's way more controversial. But that's really, if it's less than one, I start to worry that the egg number is going down. And then the other thing that's a much more subtle is that day three estradiol, if that's starting to creep up, say that's like 70 or 80, we like it to be less than 50. even if, if that's a well-timed study and somebody on day 2 or day 3 of their cycle has an elevated estradiol, that tells me that their FSH is already being pushed down by that elevated estradiol.
Yeah.
And
Yeah.
why is their estradiol elevated on day 3? Like probably because their FSH started to rise in the end of the
Yeah.
luteal phase. And there's something about
Yeah.
their, again, not necessarily luteal phase deficiency, but something about their feedback mechanisms that is now
Right.
starting to be consistent with the perimenopausal, transition ovarian
Right.
aging. And so that's another thing. Even I think a lot of general OBGYNs don't know is that
Right.
a normal FSH in the context of a high day 2, day 3, estradiol, that's not good. And I don't like to see that. And that also suggests it's harder to get somebody a cycle going, especially
Yeah.
if they're not on some sort of priming before their IVF cycles. And so I just wanted to mention the
Yeah.
nuances are really important
Oh,
too, because
absolutely.
yeah, it's
Absolutely.
not just these like big blocks of things that we were taught in training.
Absolutely. And it's also very important, in my opinion, as a generalist, is to acknowledge what you don't know or what you don't
Mm.
understand.
Yep.
Because, especially in a busy practice especially of obstetrics, you know, uh, some of these nuances, like you mentioned, you have to spend time, right? You have to spend time, with these patients and understanding each individualized, factors and run the tests or do the monitoring. I think it's very important for generalists to recognize where their shortcomings are and then to refer because these
Refer.
patients
Yeah.
they don't want their time wasted, and
No,
physiologically and chronologically they don't have the time either. So
that's
it's
right.
kind of, I just think that's so important to emphasize too, because I am the very first to say to my patients, if you want this, let's move this needle forward faster by putting you
Yeah.
in the right hands, because I can do all the testing in the world, but if I don't also understand everything, then
Right.
I'm wasting your time. So I think it's important that we, even as providers, have to be okay with not knowing everything. And if we don't
Yes.
understand it, move it forward quickly, especially for the infertility patients, because time is not always on their side.
Right. And we always say, like, if you're over, now it's changed. Like, if you're over the age of 35, you've been trying for 6 months, or if you have a prior diagnosis of infertility, right? So, like, that's something
Yeah,
we think about. It's not like, oh, you had a kid, you're good. But if it took 3, 5, 6 years to get there, as soon as you want to have another one, if that's in
yeah,
your desire, go see
yeah.
somebody, because a previous diagnosis of infertility is not erased once you have a kid either. And so, I
Correct.
think that, or, there's also this caveat: if you're under 35 or anytime you're anxious, like if you really, really, really want to have another kid and you've been trying for 4 months and you're super anxious, really, there's no harm in seeing somebody. As REIs, we're always happy to see
Yeah,
somebody rather than say, oh no, tick, 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 wait another 8 months and then come and see us. I mean,
right.
we may say, try a little bit longer, everything looks good. But if we find something,
Yeah,
women know their bodies too. And
yeah,
so,
yeah.
we're always happy to see people on the sooner side.
I also think there's also this bias that it's always first in the woman, right?
Yeah, right.
I tell patients very quickly, no, right, Erica? Like it's so important to sit this couple down and say, listen, we need to look at both of you, not just
Yeah.
one before the
Oh,
other. It's got to
the
be both. It,
resistance is
it,
so severe.
absolutely.
Is so
And
severe. Yeah.
I feel for the women who come in by themselves for those
Yeah,
for
I
those
do too.
visits.
I do too.
I
And
go,
I
where's
think
your, yeah,
I mean, I will say, like, I, practice in the state of Vermont where, there's data that people are drinking less alcohol and they're smoking more pot. And the amount of marijuana associated sperm, abnormalities that I see. And I mean, fortunately, most of the time it's reversible if men are willing to make that lifestyle change, but often they're treating their anxiety, and men aren't supposed to have anxiety and all, all that stuff. But like, I think that if I can see a couple together, assuming it's a heterosexual couple, then we can do an awful lot for helping people to uncover those, problems. And if up to 40% of infertility is combined
right?
male and female factors, even in the
Yeah,
face of a prior delivery, people are like, oh yeah, well,
yeah,
I just want to focus on me first. And I'm like, okay, I'm just going to be very blunt. Okay, so you're going to
yeah.
waste 9 to 12 months of your
Yep,
life, and then we're going
yep,
to find out that there's something we could do.
yep.
Even POI. I mean, this is about perimenopause. Like, I was burned early in my career. Again, we're sharing kind of some of the mistakes we
Yeah,
made. And I always tell my trainees, I'm like, okay, if somebody has primary ovarian insufficiency and you're telling them there's nothing you can do in the office that's going to help them more than what they can do at home, and you haven't checked the sperm, I mean, you could
sure.
literally have people be trying for
Yeah,
years when
yeah,
there's no sperm or few sperm there. It's such a simple test to do. thanks
Yeah.
to COVID, we even have men able to do this, in the privacy of their own homes. If they live within an hour, they
Right.
drive in, drop off the sample. I always say, in Vermont, don't leave it on your windshield. Keep it close to your chest, but drive it in. Right? You got to be very specific. But like I've had people with POI, and there's also a male factor. And then if you can, increase the chances of their natural fertility by addressing the
Right.
male factor, that could be the difference of a kid for that person potentially.
Yeah,
So it's, again, all
absolutely.
these nuances, listening to the person, what's in our wheelhouse, what can we intervene, and then
Absolutely.
don't ignore the man because about
Yeah.
half the time there's something in that realm, right?
Yeah, absolutely. And
Yeah.
I think also too, for me in the way I've counseled patients also is to always encourage the patient to always not to neglect herself. Don't neglect your health in the meantime. Try to get as optimal as you can. I always try to
Yeah.
encourage that message because at the end of the day, if it somehow happens, whether, it's through spontaneous or, through IVF or other means, you want to always encourage them to be healthy
Yeah.
because I do sense that some patients, some women get, they get anxious, they lose sleep, they're always thinking about, the anxiety that comes with infertility many times, but they fail to take care of themselves as well. And so I
Yeah.
try to make sure that that messaging is strong as don't forget about yourself. Keep, stay healthy, be as optimal as you can be when it does happen, right?
Yeah. And
So
I mean, I know this is also a controversial position, but I'm seeing it a lot in my practice, my, physician practice and my coaching practice, that stress is really not
it's
good for
a
the process.
real
There's,
factor.
you know, physiological reasons why the hypervigilance, the, adrenals get engaged, and then there's all this cortisol, and then it's harder to lose weight and maintain weight, and like it all sort of compounds. And so I'm finding that when I coach people and I really do increase that mind body connection and reduce the stress, like
Right.
that's when people, whether it's outside of treatment, whether it's
Yep.
ovulation induction, whether it's IVF, like the treatments work better when we're less stressed. And again,
Yeah.
like I said, controversial. People are like, don't shame people. I'm like, I'm not shaming anybody, but if there's something we can do about a modifiable variable, which
Sure.
is named as stress, like,
Yeah.
why don't we intervene at
Yeah.
that access point?
Well,
Yeah.
what's interesting about us as physicians, especially if we take call, right? And or you're still delivering, as an obstetrician delivering babies, and that's happening at any time of the
Mm-hmm.
night, you think about the sleep deprivation factor.
Yeah.
I remember very vividly days where, I would get up, start the day at 5 in the morning, whatever, be at my office, head to the, hospital because I had a prime up in labor, and then there were issues. So I was at the hospital just kind of waiting it out. I'm there. I finally get a delivery done. And then it's 6 o'clock the next morning, and I have to
Mm.
get ready to go back to the office. So
I remember, and I mean, I never practiced obstetrics after residency, but I remember being in the hospital,
yes,
going in for my 24-hour shift, doing the full work, seeing the change of shift because the nurses worked the 12 hours, seeing a whole fresh new group of nurses come on. And then the next morning, you're seeing that same group of nurses that you saw the previous morning, showered, fresh, rested.
yes.
And I'm like, wait a second here. I've done none of those things.
Right. And so it is a reminder
Yeah.
to us female physicians as well. Like the stress is real, but because we often make the choices of what we do professionally, it compounds
Right.
that whole situation. And so when
Right.
you're going through 36-hour days
Right.
and so just by nature of the beast of being sleep deprived and
Yeah.
your cortisol levels are high because of that, and then you're working on your health concerns, it can be
It's
a
hard, and fitting in fertility appointments. I mean,
horrible
I really do
situation.
help people scale back, scale back. Maybe it's
Important.
they go to per diem if they're an ER doctor, maybe they negotiate a different call schedule. Like, I think we
Yeah.
really have to look at, like, and I'm sure you know the statistic, 1 in 4 female physicians has infertility. That's more than the 1 in 6 in the general population. One in
Wow.
three female surgeons has infertility. And I think it's
I
everything. It's our diets, it's our
believe it.
sleep, it's our
Yeah.
stress levels, and but things can be done about this. We just have to,
Yeah.
like you did, put ourselves first.
Yeah.
I
And it's
wanted
a
to
hard
go ahead, go ahead.
just very quickly, and it's a difficult decision to do as a female physician,
It's
right?
hard. It's so
We
hard.
we've worked really hard to get where we are. We are very proud of the work we're doing. We're balancing a lot of different factors in our lives, and so we're proud. We're almost a little too proud sometimes,
Yeah.
right?
Yeah.
And so I think sometimes it is takes a colleague or somebody, outside of our circle, sometimes someone objective to remind us, you need to take a step back, or you need to realign your thinking or your approach.
Yeah.
And so sometimes that's important to get that kind of support, you know.
Yeah. No, you're right. It's really hard to do, but I think it's really necessary.
Yeah.
I wanted to speak to what it's like to be having like perimenopausal symptoms and to be trying to do fertility treatments, because from my experience, perimenopausal ovaries just do not act the same way as ovaries that are not in perimenopause. They just don't. And if you look at the data, if you look at like what percentage of infertility is diminished ovarian reserve, most of the data says it's about 20 to 30% of people. And of the female
Yeah.
physicians I serve, that's usually in the diagnosis somewhere, for at least half of my physician patients and clients. So, there's many reasons for that, delayed childbearing and all those things, but it's a real thing we have to focus on. So, a lot of this is hard because it's like, okay, you're doing this IVF cycle, so we're gonna put you on a birth control pill, to suppress your ovaries for timing reasons. Then we're gonna take you off, and then we're gonna do a stem cycle. I mean, and then it's like, okay, when's the period going to come? Because the period dictates when I can start another cycle, a frozen embryo transfer cycle. Like, and when the ovaries don't behave, according to the same rules,
Yeah.
we see people regularly ovulate through their protocols because the brain is on such overdrive. We
Right.
see
Right.
periods not come when they're supposed to because of that, like, long duration. Sometimes it takes longer to grow a follicle. There's all these different aspects
Yeah.
that we see. Oftentimes we have to supplement luteal hormones because the ovaries just don't work
Right.
as well in the luteal phase.
Right.
And sometimes people have allergies or intolerances, and it can get kind of
Exactly.
tricky. I do think there is something really particular about working with somebody who understands perimenopause, because the gaps, especially in between treatment cycles, the understanding of the physiology when people
Right.
are in cycle. Like, I have one person who's dear to me in my life, and she, unless she's on Lupron, she will ovulate through every single protocol. Again, not because she's trying, but because her brain is
Yeah.
just is on such overdrive to try to get her ovaries to work, that birth control pills aren't suppressive, antagonist isn't suppressive, like nothing is suppressive enough except for Lupron. And so we do have tools in the toolkit, but just to say, and I take
Yeah.
people out of frank menopause. If somebody is 50, they meet the love of their life, they want to transfer an embryo, with donor egg or donor embryo, I will do that, because you need a uterus. You need an intact uterus to be
Right.
pregnant. That's all
Right.
you need. But figuring out how we're going to get there with ovaries that have,
Yeah.
like I say, they're feminist ovaries. They've gone rogue. They're not listening to the
Yeah.
patriarchy. It can be a challenge, right?
Yeah. I think it's, again, it's a twofold approach for me. It's, as the provider, you have to be very honest.
Yeah.
You want to be, we always want to be supportive and encouraging, but there's a level of honesty that we really truly have to have
Mm,
with patients. But we
yeah.
also have to invite their honesty as well, because sometimes we also get very, narrow-minded and thinking, well, they're here for infertility, and so, this is all we're going to talk about, and we don't widen the scope a little bit and really invite the conversation fully.
Sure.
And so, I think we just owe it to ourselves and to our patients to be always as wide, almost holistic in a sense,
Yeah.
so that we are not missing certain things, but we're also having honest conversations about, okay, these are all the possibilities, and these are all the things that you might be
Mhm.
going through, and we just have to encourage at least for me, encourage the patients, like, it's going to be a roller coaster. There are a
Mhm.
lot of highs and lows, and we have to be ready for that. And so, and then
Yeah.
unfortunately, if the outcomes are not where we want them to be, we also have to be prepared to support that emotional need, those
Yep.
needs. We can't just say, okay, well, we're done. But so I think there's this, for me, this level of sympathy and empathy that we just have to really maintain the whole time,
Yep.
because
I totally agree. Yeah.
it, for lack of a better phrase, it's a shit show,
It is
right?
yeah. And I
So,
think people appreciate that. I mean, I always, whatever I'm going to say it with love, right? That's sort of my parting line. And you hear this term brutal honesty. I hate that term because like that just it
Yeah.
feels like this like sharp, edgy,
Yeah.
like
It doesn't, no, it doesn't have to
violent.
be like that.
No, and I'm like people want to know if people ask me a question, I'm going to be very direct and honest because there's no serving people is not beating around the bush or saying things just
Yeah.
because it's uncomfortable to say the truth. Like I think if we speak with love, and I mean, I think you do this really well with your patients as well, like having that rapport build up ahead of time is so
Yeah.
important
You
because
have to
when
earn the
these
trust.
hard
Yeah.
conversations happen, you know, people need to be guided and people
Correct.
deserve to know what's going on in their
Yeah.
bodies. And sometimes there is that ambiguity, but that commitment to figuring it out, that commitment to guiding people through
Yeah.
whatever those new results show, I think it's really important.
Yeah. Yeah. So one of the things I also had mentioned earlier was also for the provider to be honest, right? Like to him or herself, and
Yep.
in this case, herself. And the fact of the matter is that if you have, if you don't have the knowledge or the skill set, move it forward. Don't waste
Yep.
that patient's time and
There's no shame in that. There's
there's
no
no
shame in
shame in
that.
that.
Yep.
And be honest with them because if you
Yep.
don't know the next steps or you don't understand the blood work or you don't know how to have the conversations,
Yep.
be honest and move them forward to somebody else who can.
Yep.
Because
Yep.
I just think a lot of times, especially in the beginning, I think patients' time is wasted because providers, I'm not saying in this group particularly, but there are a lot of generalists and a lot of primary cares that are just not willing to admit that they don't know.
Yeah. And
And
then
maybe
it's
that's
okay. I mean, we
broad.
can't be good at
Yeah,
everything. We just
right.
can't.
And I maybe that's a little
Yeah.
too judgmental, but maybe in my patient population, I've just seen it a little bit more.
Yeah.
And so I always tell patients, if I'm not the one, I will find you the one,
Yeah,
right?
that's right.
That's yeah.
And
So
people see me because, things haven't worked yet. Nobody
right.
gets to me because they're at the beginning of their journey and they're like starry-eyed, oh, we're gonna do
Yeah.
one cycle and it's all gonna be fine.
Yeah.
Like people see me because they're like, listen, I've done 5 IVF cycles and people say it should have worked by now and it's not working and there's something that's missing. And like, I think especially in those situations, we have to
Yeah.
really be honest. And I mean, there are even times when I'm like, you know what? Like you've had 11 losses. I think there's something going on with your immune system. Like I will refer you. I mean, I do this too, right? And so I think we all owe that to ourselves
Sure.
and our patients in the medical community because we are a community, right? It's like
Yes.
if my family member has something that's super complicated, I'm going to go to the expert in that thing. And the more subspecialized we get, like the fewer people are going to be able to help people with those specific
Yeah.
things. So
Yeah.
yeah,
Yeah.
makes total sense.
Yeah, the conversations that we can have about this are so they're just so extensive. And I think
Mm-hmm.
at the end of the day, we just have to really, just lead partly with our hearts too.
Yeah,
There's so much emotion that goes into taking care of these patients.
yeah.
And in physicians, we're humans too, right? So
No, I know. We forget that. We really do forget
yeah,
that.
yeah,
I wanted to sort of, as you take care of your patients who are going through infertility, what are some of the gynecological concerns that you want to make sure that people have
yeah.
addressed, right? Like obviously, fertility specialists taking care of the fertility, but like what are some like, basic checkbox
Yeah.
items that people should make sure they're taking care of?
I always start with anatomy. I always say, let's just rule out kind of the easier parts of this whole picture. Let's
Yeah.
look at the anatomy, especially for someone who's never been pregnant. Let's just make sure everything is there. Everything is, or the things that are patent, that need to be patent are patent, you know.
Yep.
So I always like to start off with the approach of anatomically. And
Yep.
once we have reassurances that there aren't any concerns from an anatomy standpoint, then I move, not always, you know, sometimes I'll do this obviously at the same time. I'll also look at the blood work and try to
Sure.
make sure I'm doing it at the right timing, at cycles. But it's also taking really good histories of these patients and also looking at their environments, their nutrition and recreational things that they may or may not be doing. And
Mhm.
you and I had said this before, if we're fortunate enough to have their partners heterosexual partner in the room, we need to be having kind of that same conversation about, their health too. But for the patient herself, the anatomy, obviously the blood work, and then recognizing if there are other risk factors like smoking,
Yep.
if there's a very high BMI,
Yep.
maybe evidence of PCOS, endometriosis, things like that. So for me as a generalist, what are the things I know well? What are the basic things I can get started for my patient? And then from that
Mhm.
point on, am I equipped and qualified to take the next steps? Right? So that is my approach because I feel very strongly that when I meet the point of where I'm not that I can't make the next move with that patient. I want to be able to tell that patient very quickly, okay, these are the things we've done, these are the things we know, and this is where my limits are at this point, and I would
Right.
like to move you forward. So that's typically my approach with my infertility patients or
I
patients
think that
that
makes a lot of sense. I mean, for me, it's a dream if somebody comes to me for a new patient consult and they have all those things done because we can just start off at a higher level. It's
yeah,
really beautiful.
yeah.
So
And
thank you for doing.
I'm also
Yeah.
very adamant about sending for semen analysis all the time. Like if the partner is going to give me pushback, I am
Yep.
very blunt and I'm saying you cannot put this all on on the female.
Yeah. Yeah. That's
So
great.
I make it mandatory for semen analyses to be done as well.
Great. Good for
Yeah.
you.
Yeah.
I think as it should be,
Yeah.
really.
Yeah, and
Um,
and then also there was something I was thinking about, but as I've also kind of pivoted into perimenopause and menopause, I also, we look at the age group, and I start to bring up perimenopause and some of
good.
those, aspects of it, and so because I don't want the ball to be dropped on them later and be like, well,
Correct. That's
nobody,
right. Oh my gosh, how many people deliver a baby and then their periods never return? They're like, okay, well, I breastfed for 4 months and then my periods just never returned. And then you check an FSH and it's like super high. And it's like, okay, your timeline is shorter. Like, be
yeah,
prepared.
yeah,
It's not all breastfeeding symptoms. Like,
right,
this is
right,
probably perimenopause, menopause. And so you're
right.
right. Just
It's
looking ahead, this is what you might expect. And don't be
absolutely.
shy about coming to see me sooner.
And
Yeah.
that I think is also part of the failure of our training, because
100%.
we're
Yeah.
very regimented to think, okay, here's pre-pregnancy, here's pregnancy, and here's the 6 to 8 weeks postpartum. And we get
Mhm.
so one-track minded and we forget that no, 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 let's pull back here a little bit. Let's
Yep.
look at if she's 44, she just had a baby, at 43, what are the other things we absolutely need to be involved in talking about in this conversation?
Yeah.
So it is I'm happy that I'm happy that I'm including that more in the conversations because I didn't in the past because I was one of those that just was initially trained to think one way, like it's this and
Right.
it's this and it's this, right? So yeah,
Yeah, no, you're absolutely right. And then I will also throw in there, gosh, the healthcare maintenance, the routine healthcare maintenance
oh
gets
yeah,
missed. So I always say like, okay, when was your last PAP? And I know it's controversial.
absolutely,
I'm like,
yeah,
I cannot treat you until I've seen women present
yeah,
with stage 4 cervical cancer in the
yeah,
US, because people just said, oh yeah, I'll do that. I'll do that later. I'll do that later.
yeah,
And then later is like cervical cancer. And so
correct,
got to have a updated pap smear. I mean, the
yeah,
guidelines have changed. And so if you're over 30, you can kind of go maybe 5 years if you've had normals in the past. Again, talk with your gynecologist about your exact paps, but you need an updated pap. And then mammogram. I mean,
mammograms,
especially if a lot of
yeah,
our patients are in their early 40s, mid 40s, and or maybe earlier with a family history, like I'm like, okay, you need a mammogram. Like, we're not gonna get you pregnant and then figure out you have breast cancer. Like, that's not gonna
yeah,
happen. And so so let's
yeah.
figure
I
that.
think
And even colonoscopy sometimes too. Yeah.
absolutely, because
Yeah.
it still behooves us, right? The basics of
Yeah.
preventative care
Yeah.
don't go to the wayside, just because we're
Correct.
tackling, concerns about infertility. We need, like, I tell patients all the time, let's make sure you're as optimal as we can get you.
Correct. Yep.
So colonoscopies, mammograms, pap smears, right?
Yep. Yep.
Even for some, maybe their bone densities already,
Yeah. Or
right?
skin
So
checks, if somebody has a family history of
absolutely.
melanoma,
That's
like,
such an
don't
important
forget
one.
about the low hanging fruits. Yeah.
Yeah.
Mm.
Yes. Yes.
Yeah. So that all makes a lot of sense. Well, is there anything else? Okay, I wanted to ask you this question, so I'm going to ask you. You mentioned on your website that you see menopause and perimenopause as an awakening. Can you say more about
Yeah.
that? Because I really want our listeners to hear your thoughts
Oh,
about that topic.
so, there, and part of this will come from personal experience. I there's the early years when we're thriving. We're excited, we're hopeful, we just look to the future differently because we're younger, we're thriving, and everything's going well. And then for those that take the next steps of maybe marriage or long-term relationships, starting families, um, we get immersed in those things. You come out of it, and in my own experience just recently with my own children moving on to college and now being an empty nester, the shift in my own body through perimenopause and now menopause, or being now postmenopausal, the shift in my career that was kind of forced on me, that I had, or the decisions I had to make to really figure out what I was going to do. I think all of it, like this perfect storm of things, and you come around and you're like, you have a choice. It's sink or swim. And if you're going to swim, you've got to find that self-confidence to believe that if we're living now to about another 30, 40 years, that there is still purpose
Hmm.
and that one can still be impactful. Whatever decision you decide to, make in your life, there is still purpose.
Right.
And that's exciting. We
It
don't
is
have
exciting. Yeah.
we don't have to think it's an ending, right? But we open another door and we say, "Hey, there's a whole lot more out there, and I'm in it. I'm all for it." And so I think the reason I feel like it's an awakening is because I want to remind women that it's never an ending unless you want it to be,
Hmm. Hmm.
or there are unfortunate circumstances in life that maybe make that seem the likelihood. But we can just look forward and be excited,
That's
especially if
right.
we're taking care of ourselves and we feel good. It's hard for perimenopausal women, menopausal, and postmenopausal women to feel that level of confidence and reassurance if they don't feel well.
It's true.
And
And,
so,
and also if they haven't met their goals of family building too, I think that can be very challenging for people.
of
And so I
course,
think
yeah,
optimizing both at the same time, I think is really important. And,
absolutely.
most people's strong plan A is to conceive with their own DNA and, and all of those
Yeah,
things. We maximize that, of course. I do have the conversation with many women about donor egg. I mean, even in my career, that has taken a huge leap
yeah,
in terms of helping people with that too. And so I always say if the desire is in your heart to become a parent, it's there for a reason and there are pathways. And so also having really science-based conversations about the opportunity for donor egg IVF, if that's the way somebody feels called to build their family or even donor embryo. I think those are important because this transition does not need to mark the end of fertility as such. Like I
right.
said, I take people out of frank menopause, especially if they've had their health
Yeah,
clearance and everything. And so
yeah,
if
yeah,
the desire is in your heart, yes, we'll optimize the hormones and we'll figure out a way for you to build your family.
yeah, exactly. And there are some realities of what happens in the hormonal transition. When you look at the divorce rate, when we look at suicide rates over the
Mm,
age of 40, and if you even just took the number one killer of women over the age of 40 is still heart disease. Like, we have to have the correct conversations around all of those issues.
yeah,
I will never tell a 50-year-old, you're done.
yeah,
Whatever she wants for herself, it is my job to provide as many options and to encourage where we can optimize the health, where we can get her to a better place. Because I'm not the judge. I am not
right,
the one that determines the future of that patient. She
right,
does. And so it's our job, and I fully support this. It's our job to make sure that we're the guardrails. I always tell patients, I don't determine your future. I'm just there to guide you to make sure
yeah,
that you can make the best possible decisions for yourself at any age and whatever you want at any age. I'm hoping to be the one that can guide you to get you to that place. So, yeah, so I guess awakening is the word I would use in that broad sense. But it's never an ending. It's an exciting time to be, for me, I feel excited at 55 to look to
Yeah.
the future. So, yeah.
And I think it's a questioning. It's like a questioning of the truths that we've held so dear and true. And like, we actually ask ourselves the question, like, what do I want? What do I
Right.
want? What's giving my life meaning? What can I say yes to? What do I need to say
Yeah.
no to? It is
Yeah.
exciting. It can be a little scary. And I think it's best if we
Always.
can do it
Always.
in community where people are also going through and have
Yeah.
guides and everything.
Yeah.
But I think it's really exciting because I mean, for me personally, a lot of things that I held to be true, starting to question those things and it opens up new possibilities.
Sure. I do
Yeah.
think we have a particular responsibility as female physicians because we are blessed with the knowledge of having gone through medical school, having gone through residency training. We have a special understanding of the body and
Yep.
all the other facets that go with it. And so we have that slight advantage, as opposed to someone who doesn't. But it's also a double-edged sword because I think we're also the first to also not take care of ourselves as easily or as quickly as we should, maybe even just go through a little bit of denial for ourselves. So we have a particular interesting balance to maintain, I think, as female
Yeah.
physicians. So
And
yeah.
that's why I love helping clients. I mean, that's people say,
Sure.
oh, and I do. I have clients who are in
Yeah,
other aspects of careers, and those are so gratifying. But I think really helping women physicians like be the patient and relax into that role in
absolutely.
inappropriate circumstances, I
Yeah,
think is really
yeah,
empowering.
yeah.
Amazing. Well, Dr. Tina, thank you so much for coming on the podcast and sharing all of your
It was a
wisdom, your
great
approach to patient
conversation.
care. I know, and like just talking about perimenopause and your experiences, my experience. I think this conversation is really going to reach so many people who are in those very situations and looking for
Right.
help, looking for answers. So, where can
Correct.
people find you?
Well, I am located in California. I have my license is to practice only in California, but I have a robust telehealth practice as well, and I'm in two different locations, about to start a third. I have an Instagram account, the Dr. Tina, and a website as well. And so, yes, it's not too hard to find me. My last name is pretty particular, so. Uh, but I am trying to also, like you, get out there to have women have these conversations, to empower each other, to keep the conversations more normalized, whether it's perimenopause, menopause, infertility, all of
Mhm.
the above. Because the more we have these conversations, I think the easier it is for everyone, hopefully, to seek out and be the care and be advocates, better advocates for themselves, right? So, and to push back to us providers a little bit.
That's right. That's right. They told me medical school, my greatest teachers would be my patients. And that has
Absolutely.
a lot
Thousand
of
percent.
things they said have, got outdated themselves or gone away, but that has continued to be true. And my patients ask me the best questions, my clients too, and
Yeah.
it keeps us on our toes. And that's the
Yeah.
point. I'm like, this is Dr. Tina 2.0. Like
Yeah.
you're evolving, you're evolved. I can't wait
Yeah.
to see 3.0. We
Yeah.
keep evolving, we keep growing, we keep helping each other. So again,
Absolutely.
we'll put all your info in the show notes. Thank you so much for being a
Thank
guest. And
you. Thank you for having
to my
me.
listeners, you're welcome. And to my listeners, you know how much I love you. Until the next time, bye.